Evening, everybody. On behalf of the uh, actual panelists in their absence, I take this opportunity to become the panelist. And let's start this session before it is too late to start. So first of all, I'll request if Dr. Harbhajan Lal is there. If he's not there, in his absence, I'll request Dr. Deepti Kulkarni to present her paper on the classic SFIOL, Old is Gold. So she is Dr. Deepti. If any of the panelists, if they come, please take the seat.
Good evening. My regards to all those who are present here. Why I call this old is gold is, there has been a lot of discussion about the type of scleral fixated IOLs, about when you should do them, about when it is not supposed to be done, what happens to the rest of the ocular tissues, what about the inflammation, what about the vitreous, and will the SFIOL trigger any kind of additional inflammation after doing it. So I prefer to do the sutured SFIOL, wherein to make the side flaps, just like we do in TRAB, I measure it with a caliper, mark the caliper with a marker pen so that it's easier to delineate the flaps here. I'll just run through this video. And then create the flaps on either sides after measuring them so that they come out nicely. And then once the flaps are ready, I fashion the tunnel. I use a frown incision, so that's how I make the tunnel. Why is it not going ahead? Okay. So after the flaps are created on both sides, in this case, I had also done a vitrectomy, and hence the pars plana vitrectomy infusion port is here. I measure the distance from, this is an ab externo technique, so where we measure the distance from the limbus. Here I pass the straight end of the needle, and then through a handshake, receive it into a 26 gauge needle from the other side. And then we bring it out. So in this process, we are not doing any kind of manipulation intraocularly. So the risk of inflammation is thereby reduced again here. After this, once the needle is out through the other side, then I pull out the suture using a McPherson or any suture holding forceps through the tunnel, clip it into two pieces, and then tie it onto the IOL, onto the eyelet of the regular SFIOL. Once it is tied on both sides, then we can grasp the IOL with either an iris claw grasping forceps or a McPherson, whatever we are comfortable with. Insert it inside the anterior chamber and carefully adjust the sutures on both the sides. In this technique, what happens is that since most of the procedures are done extraocularly, where that is suturing of the IOL, passing of the sutures and then cutting it, all that is done extraocularly. So the intraocular inflammation is very minimal, or rather absent unless we have touched the iris for any reason, like to release some Synechae, or if we have had to do a PBI for any cause. Once this is centralized or centered in the pupillary space, then we can tie on either sides, and then this is done. So why? There have been many modifications of the SFIOL, where a lot of people now prefer Yamane technique. There's a chariot technique, then there is a lot of glued IOL being done. But the latest technique, the Canabrava technique, where he uses 4 flanges, can also be done for this similar technique. In this technique, what it does is, where we suture the IOL in the classical case, he uses a thicker suture, a 5-0 or a 6-0 nylon, polypropylene, and that with the ballpoint cautery or a heat cautery, it's made into a dumbbell, which again locks into the eyelet. What I feel is there have been a lot of studies comparing this glued IOL versus the Yamane technique, and which one is better and which one is less. But honestly, there has not been an unbiased study comparing the a classic old sutured SFIL versus the more efficient or lesser handling techniques like the Canabrava technique. So perhaps if we can take on a multi-center study where we do compare all these cases in clean cases, where the surgeon is sure that there has been no complicated cataract surgeries which led to performing the SFIL, perhaps you can get more unbiased results. Hoffman pockets, instead of these flaps that I fashioned, Hoffman pocket is perhaps easier to fashion for those who are not used to creating a scleral flap, wherein the pocket is created just like a scleral tunnel, partial thickness, and then the knot is buried into the pocket, and so the knot is again not exposed beneath the conjunctiva and does not cause conjunctival erosion and thus foreign body sensation. So moral of the story, I think sutured SFIL is a safer and sturdier option because we've had previous 5-year studies which show us the safety of this procedure, and if done well, perhaps this can be our go-to technique in cases where the bag or the zonules are not there. Thank you.
How can you put in a knot inside a Hoffman pocket? It's a single thread. You are taking it out from the either side through the bed of the, the scleral bed
so
of the
here,
flap.
Here I have made flaps here, but in the same way that these flaps are created, if there is a Hoffman's pocket which is created here with the opening towards the limbus, then the suture is passed through the Hoffman's pocket, and the same procedure. Pass the needle from here, come out from here, there is another Hoffman's pocket here.
So it is a single thread of nylon which is holding it?
Yes. So it comes through and through, pull the suture from the center and then tie it outside.
Okay.
My question is, there are just two contact points. One is in this periphery and the other is in the other periphery.
Yes.
So the chances of lens tilt and the astigmatism, it is very high.
Higher. Yes, sir. So the Canabrava technique which is described recently has 4 flange points, which perhaps negates this complication of lens tilt. But then even in limited means when we have just the regular eyelet SFIL with us, perhaps you can measure and mark the axis that we want to do. In fact, in this case, we even did a toric SFIL where we marked the cornea just like in a toric IOL, and then we placed the SFIL, measuring at every point, like measuring while inserting the needle, measuring while creating the flap, and marking it beforehand itself.
What I want to emphasize is, you have got 2 touching points. One is this end, the other end, this end, and is tied but 1 knot each, right?
Yes, sir.
So the chances of tilt of the lens is high.
Higher.
So that's why, it's not so popular.
Yes, sir.
Otherwise, the paper is fantastic.
Thank you, sir.
So you mean to say that that Canabrava technique has got 4 fixation points
Yes.
that will prevent the lens tilt?
Yes, sir. He has been using a 4 plate haptic or a similar 4 flange technique.
Have you seen anybody using this white sutures, this
Gore-Tex sutures.
Gore-Tex sutures?
Yes, many people do prefer Gore-Tex to polypropylene, but I am still using polypropylene and it's working fine. I use 9-0 now instead of 10-0 because 10-0 is a little difficult and flimsy to handle. 9-0 works fine, sir.
Okay, thank you. Nice technique.
Thank you.
Sir, the next speaker would be Dr. Harvang Lal has come, sir. I've seen him coming. He's not there. He came here? He came in? He went away. Anyway, so who would like to present next? Please go ahead. He's Dr. Amiya Kulkarni. His area of interest is phaco and refractive. He's also into pediatric and community ophthalmology. And he's an avid teacher. He loves teaching. Am I right?
Thank you, sir.
So he
I really like what you said about teaching. People usually leave that out.
Also an assistant professor of ophthalmology at Bharati Vidyapeeth Medical College and Hospital, and would like to teach very much. Okay, let us see how much he could teach us. All ears to you.
Yeah, so posterior polar cataract has been an area of interest for me primarily because in cataract there are few what I like to call final frontiers where we still haven't been able to consistently give results in all the patients all the time. So posterior polar cataract is one of them. What happens in posterior polar is there is strong adherence of the opacity to the weak posterior capsule, 26% likelihood of defective posterior capsule, and these patients are 40% more prone for intraoperative PC rent. Now, why posterior polar cataract is different, we'll just come to it. In posterior polar cataract, counseling is absolutely critical. You have to tell the patient about possibility of PCR, possibility of nucleus drop. There might be a need for VR intervention. You have to counsel about long operative time because the rest of the patients getting operated with him come out of the OT in 10 minutes. If this fellow requires 20 minutes, the relatives are going to be anxious and obviously delayed visual recovery. Now, let's see why posterior polar is singled out or different. What happens, all of us in our residency are taught a good phacoemulsification or nucleus management involves thorough hydrodissection. You rotate the nucleus and you start chopping and lateral separation before you start taking it out. Now, what happens in posterior polar cataract? You cannot do thorough hydrodissection. You should not rotate the nucleus, and there's no question of chopping and lateral separation of the nucleus. That is why there have been various techniques described. So I'm here presenting a technique that I have been using for the last 3 to 4 years. This is what we do. We make a good CCC, and you can see here I'm doing only hydrodelineation. As we all do, we don't do hydrodissection in a case of posterior polar cataract. Now, once this thorough hydrodelineation is done, what happens is you are creating a plane between the central part of the nucleus and the posterior polar part, which is in the periphery, which is posteriorly, and this is where I pop this piece of nucleus out of the bag. Now, once you are able to pop this out, you will see that once you have popped it out, you can tumble the nucleus, you can flip the nucleus, and again, then you can start rotating, and you can do everything with the nucleus that is basically not allowed when you are operating on the posterior polar. This is just a question of popping the central nucleus out, and once that is out, you can see everything can be done nicely. Why this happens is because in the bag, you cannot, if you try and do these maneuvers in the bag, you will be transmitting those vector forces onto the capsule, stretching the capsule, which then basically reaches the area of posterior polar dehiscence, and that is where you have PCR and nucleus drops. Once this is out, it's just a question of taking out your material. Once the central portion is out, the case becomes much simpler. As we all know, the basic aim of operating a posterior polar is to touch the posterior polar area the last, and this is how we deal with it. Now, in this second case, you will find that the central nucleus is slightly larger than what we saw in the first case, but still you can do this. Now, the technique of taking it out or popping the central nucleus basically came from SICS. My generation of surgeons we have all started doing SICS, and then we shifted to phaco. So this becomes easier for us, and this is how you can tilt it. If it is larger, you don't need to take the entire thing in the AC, but you can tilt it, and then you can still do all the maneuvers that you were doing before. By this technique, basically it takes away your anxiety of peeling it layer by layer. What happens if your forces reach the posterior capsule? What happens if the fluid that you are using through the probe reaches the posterior capsule? So you can just tilt it out, pop it out, and chop it as if you're chopping a normal nucleus. That is how you can consistently get results even in posterior polar cataracts. Once the entire nucleus is out, you can see we haven't touched the area of suspected posterior pole. This remains untouched, you can see, and then you can take the entire thing out and then implant the IOL. So this is the pop and chop technique. So in conclusion, remove the nucleus first without disruption of the posterior polar cataract face. Peel the cortical material from outside in, leaving central posterior polar component for last, and gently remove the posterior polar cataract attachments to the posterior capsule. Thank you.
Thank you, Amir, for your beautiful technique. Very beautiful surgical skill demonstrated. So it is basically a pupillary plane and somewhat in the
Yeah,
anterior
yeah.
chamber,
Yeah.
saving the posterior capsule.
Yes.
Sir?
Yeah, I like to differentiate the posterior polar cataract into the posterior subcapsular cataract and posterior capsular cataract. If it is the posterior capsular cataract, you cannot afford to, pop out the nucleus because, it is attached to the capsule. Its capsule is attached. In subcapsular cataract, it is movable, so you can pop it out. Your technique is fantastic. And if it is a capsular cataract, in that case, you have to tackle the periphery first rather than the center. So there is some difference between the posterior subcapsular cataract and posterior polar cataract, or posterior capsular cataract and posterior subcapsular cataract. Your technique is fantastic. You're very, very nice.
Thank you.
Dr. Kashyap, I request Dr. Kashyap to present his cases. He's Dr. Birendra Prasad Kashyap from Ranchi. He's a prolific speaker and a prolific surgeon. We had been seeing him over the years, over the decades, so to speak. At his state-of-the-art eye care facility at Ranchi, he takes care. Do we have Dr. Rastagi here? Okay. Next you will be giving. So these days there are various grades of posterior polar cataract. Posterior polar cataracts are graded as various grades, and you do a OCT, anterior segment OCT will let you sort of posterior conical cataract or something, whether it goes into the vitreous.
Hi friends, good evening. So I'll be talking about the SFT, the single pass forward technique popularized by Dr. Amar Agrawal. We do it in different situations, and I'm going to present you a long-term follow-up. It is commonly used for the traumatic deficiency of the iris tissue, whether it's a primary or secondary. It's the deficiency of iris after synectomy removal, and when the optic of the PCL tends to pop out above the pupil, especially when you're doing the penetrative keratoplasty. When you're doing optical keratoplasty, in cases of congenital coloboma of iris, and sometimes to stretch the iris to avoid the crowding at the angle. I hope you know all the procedures. I'm not going to the detail, but what is desired is people should constrict, people should remain in the center, and there should be no gap between the iris tissue which is brought together. And there should be no visible holes in the entry or exit side of the iris surface. And a single SFT is more desirable than multiple SFT. These are special precautions taken. Now, experience will only tell you how much to tighten the stitches without breaking it, how much deficient iris can be repaired, and how to cut the free ends of the knot of the stitch inside the anterior chamber. It's not easy. And normally done in pseudophakic eyes and aphakic eyes, but you can do it in aphakic eyes as well. Now these are the follow-ups. This is a 3 years follow-up of a case, and the knot is good. You can see the knot is good with the growth of pigment layers mimicking the continuity of the iris. The deficient iris works like a peripheral iridectomy. And this is a case of 2 years follow-up with the 26 gauge needle pierces the anterior surface of the iris, and this entry point becomes like a PI. It's cosmetically poor. It's 18 months follow-up case, the knot may open up or break, and the effect of the SFT is nullified. It's 18 months follow-up case, the knot may open up. And in the 28 months follow-up, and the people may become eccentric because one of the SFT has given way. It is moving automatically. There is a 40 months follow-up, SFT remains intact, but the stitch is marked on the iris surface so that it avoids the crowding of the iris at the angle. In attempt to make pupil pinpointed, especially in cases of cornea grafting, because of inflammations, it may block. The pupil may get blocked, and it looks like that, but it opens up. Don't have the post-op, the picture of follow-up after that, but it opens up. This 35 months old follow-up is a good SFT, good bridging of with the pigments. A small PI-like deficiency is negligible and cosmetically acceptable. Is 20 months old follow-up and clearing the peripheral anterior synechiae with SFT and DSEC. SFT remains after DSEC surgery. This is a 14 months follow-up of case in which we had put a multi-piece IOL and is held back, and the astigmatism is neutralized to quite an extent. 13 months follow-up, corneal scar causing high astigmatism is neutralized to quite an extent. 18 months follow-up, the rupture sphincter pupillae, it's easy to dilate while operating, but SFT gives a central circular pupil with excellent visual acuity. These 20 months follow-up cases, SFT is in congenital coloboma of iris, it works good with SFT. The other side may require pupilectomy depending on the visual axis. This pupilectomy done on the other side is a 20 months follow-up case. 6 months follow-up, a small tag, you can see the tag, tag looking part remains forever. I'd never try to dilate the pupil in this case. This 22 months old follow-up cases, the SFT may become loose, but the bridge of the pigment persists. The 18 months follow-up, the growth of the iris tissue is so well that the SFT cannot be guessed. 26 months follow-up case, the rupture sphincter pupillae, the SFT is in upper and lower quadrant both, good tissue growth of SFT. 25 months follow-up case, the rupture sphincter pupillae, just one SFT in upper quadrant remains good. 13 months old follow-up case, the rupture sphincter pupillae, just one SFT in upper quadrant. The 19 months old follow-up, not enough iris tissue. Pupil so made and has a gap, and the thread is visible. SFT gap may fill up later probably. 19 months old follow-up, pupil could be made smaller, hence the stretch. It couldn't be made smaller, and the gap in the lower quadrant is visible. And 36 months old follow-up, the single SFT, the growth of the iris tissue and the pigment is good for years together. 14 months follow-up, the rupture sphincter pupillae, just one SFT in upper quadrant remains good. We had given multiple SFT in this case, and but one SFT is given me, and the pupil is no more central. Thank you very much. I'm sorry for the slide, it went automatically by one to the other, so I didn't have much of time to explain. So, do you have any question about SFT?
Can you have the lights on at the back? Ek light jala do. Just beautiful documentation, sir. It's beautiful. The slides may run fast. You may not have a control over your slide. The patients have control over their vision. No doubt they have.
Thank you. I just want to give you one tip for SFT. Point number one, at the place of entry, you don't have to make corner incision. And the other end, you have to make a corner incision. You put the 26 gauge needle. While going to the first entry side, take the needle behind the iris tissue and pierce this from the posterior surface and come to the anterior surface, and then by railroad technique you can come out. Point number one. Point number two, always bend the needle, the 10 gauge or 9 gauge needle, 90, 10, you bend the needle. How much do you bend? You measure white to white. That is the key. Number three, when you are cutting the edge, cutting the stitch at the knot inside the anterior chamber, you magnify the image and stretch the, pull this stitch and then cut it to the vitreous scissors. These are 3 tricks I'm giving to you. That will work.
Very nice, sir. And just to add, I mean, that 26 gauge needle where we do the railroading, we should not pierce the iris through the 26 gauge needle. We'll just take support of the iris because 26 gauge needle will cause a huge bore, a gap, because iris tissue is too fragile and too tender. We'll just take support and then pass the needle through it. We should not go beneath the iris with the 26 gauge needle.
Yeah, absolutely correct. Yeah.
Thank you so much. Any more questions? Somebody has a question? And do you advocate placing of, this is a single pass 4th throw pupilloplasty advocated by Dr. Agarwal.
Yes.
Did you think of at some point of time one more knot over that would secure it for good?
No. Single.
It
Single
stays
pass,
there.
4th
It's
throw. That's
beautiful
sufficient.
documentation for so long.
Yeah, because I showed you, for years together it's there. And if I had to come out, sometimes, why does it come out? Many a times you're not able to tighten it up because of some problem. And if it is not tightened up, you cannot do anything about it because again you cannot take it out and do it again. You don't get a second chance. And why does it happen? Sometimes there is some problem in the knot, sometimes some problem in the stitch, some problem in the iris tissue, they get entangled, then many things can happen.
Yes,
So,
it's not as
it will-
easy as it seems all the time. So
Yeah.
there's a very fine threads and they get entangled one over the other and you miss trail of which one is which one.
Yeah.
So you have to be very careful. And use copious viscoelastics over the iris like something like Hilon GV to make the ends visible before you cut it with scissors.
Yeah, exactly.
Clearly, as Sat said, that you increase the magnification, increase the light, see it and then cut. Otherwise you may.
And the other trick is do not be miser. Some people what they do is when they pass this stitch, they take the hook and bring the stitch to have a loop outside. When they have enough, they cut this stitch here to save some stitch and put the knot. Sometimes, this thread slips away and then you have to redo everything again. So don't be miser. Number 2, when you're giving the knot, it is better to cut the needle away so that when you're making the 4th throw, it's easier. With the needle on, it's difficult to give 4th throw.
Okay. How many of us are doing pupilloplasty? Fine. What sutures are we using? With a straight needle or a bent needle? But with Orolab, you have a bent needle. It comes with a bent needle. You don't have to bend it manually. Alcon needles are straight. I used to do that, but somebody taught me that in India, this Orolab has got a needle which is already bent in that fashion. You have both ends bent, and people not like you, a miser like me, will cut it into 2 and use it for 2 patients. But you have one end straight and one end bent, which I used to do previously. It's a little bit more difficult. You have to manually bend it. Thank you so much, sir.
Thank you.
But for this follow-up, thank you for that. I learned it that for so long it does stay. It's not a myth, it does stay. And in case of like coloboma, we all should be operating for coloboma test people. I mean, this happens with so many subjects. So should you, as you had said, you make the pupil round with one suture, reasonably good. Have you ever felt the need of giving one more suture down the line to close it down at 6 o'clock?
In the first slide, I said what is desired is you should be able to give just one SFT and that should be good. Even if you leave that, the little bit of gap, it doesn't matter. Let me tell you very practically. So you don't have to give another stitch.
Nobody has ever complained.
Yeah. So
But cosmetically, sometimes I have given for my gratification, maybe.
yeah.
Yes.
You can give 2, you can close everything, you can just leave the people, whatever it is. But then one can work, one stitch should work. It works. If you can give one, you can give this.
Sir, one question. In case of coloboma of iris cataract cases, after stitching, do you feel that the vision will increase? In such cases, if we do not stitch, the look cosmetically it may improve, but do you expect the vision will improve after stitching the iris?
Oh yes, because most of my cases had coloboma of iris with coloboma of lens, or you can say the dehiscence
Choroid
and coloboma of iris. So we operate, and then the patient is very happy, the vision improves. If the coloboma has not in the choroid and involving the optic nerve,
It
the
should,
patient's
by
vision
pinhole
improves.
effect, it should,
The only
to a
question
certain
some
extent.
the only question some people ask that the patient is used to that kind of a low people, and they are the mind is used to it, the brain is used to it. It's all, I think it's all it's not
No,
not,
apart
not
from
correct.
cosmetically improved look, the vision is going to increase or not? My
Yes.
question is that.
Yes, sir.
When after stitching, will there be any effect of that?
You can use SFT in cases of coloboma of iris, but it is not done alone. If the patient develops cataract, then along with cataract we do give the SFT. And the patient had cataract, the vision was bad, and if we've done the operation, cataract operation and SFT, the patient's vision improves.
Thank you, sir. Thank you so much. Next,
You're
we would have Dr. Inder Mohan Rastagi, Director, Triveni Eye Center, Gurugram. He's got 20 years experience, and he's going to share some with us. It's all yours.
Thank you, sir. Good evening, all. PCR management. This is from a film, and when the PCR happens, surgeon has to say all is well. If you say all is well, things of course will be easy for you, and it is a breach in the posterior capsule which is not so sweet like this chocolate, and every patient with irregular posterior capsule must be carefully examined. Already Dr. Kulkarni has explained, and as a surgeon we have to have an eagle eye on these cases of ocular trauma, previous surgical procedures, and those patients who are on chronic use of medicines. We have to see few, especially polar cataract also. And as far as imaging is concerned, of course, B scan is very much helpful in detecting these cases which are at risk, and best is 20 Hertz ultrasound. So we have to be careful at every step while doing surgery, especially doing CCC. We have to have an intact CCC. Doing hydrodissection, we should not be aggressive. Doing hydrodelineation, we should be, do it in steps, or in risky cases, we should not do it. Growing, we have to, if the, burst phaco mode or less foot pedal control or beginners, they can cause PCR. And irrigation and respiration, if the tip should not be directed toward the posterior capsule, and, this thing, the unusual sign, they must draw your attention. Management is, early recognition is important. Optimal management and outcome, that depends on early recognition. And you have to have an eagle eye on, sudden deepening of the ACs, try on PCs, sudden improved red reflex and tremorlessness of the nucleus, or difficulty in rotating the previous, this mobile nucleus, which were pupillary slabs. If there is vitreous strains in the AC, if the lens is tilted, or fallibility of the nucleus is poor, or pupillary margin is moving. So these two things should be in mind, whether the vitreous is present or not, or whether we should go with the surgery or we should convert. And all this depends on hardness and the size of the nucleus, size of the pupil, maintenance of the chamber depth, and level of the surgical experience. Principle of management depends on two. We have to stabilize the anterior chamber immediately, take deep breath, stabilize the chamber, and then assess what is to be done, what to be not to be done. If suspected, then we should not withdraw the instruments suddenly. because this will further aggravate the situation. And we should, second instrument should be carefully withdrawn with AC formed. Immediately we should have low settings, less vacuums, low flow rates and low irrigation pressure. It is always better to go slow in the right direction than to go in the wrong direction. And then again, if vitreous loss is not there, the primary aim is to prevent enlargement of the tear and prolapse of the vitreous into the AC. In nutshell, without vitreous loss, we can complete the surgery. If nucleus pieces are hard or big chunk is there, we can convert. We should reduce vitreous hydration by keeping the parameters low. And once the cortex is removed, we should always make sure that whether we have to do anti-vitrectomy or not, vitreous is not there, triamcinolone has to be used. And if at all vitreous prolapse is there, that should be removed first hand, and irrigation aspiration should not be done that vigorously to avoid further damage. And depending upon the situation, appropriate IL should be chosen. If there is a vitreous loss, then the management slightly differs. We have to make it the situation like it was without vitreous loss. We should use OVD and nucleus fragment should be removed and bimanual vitrectomy should be done, and only then we should go further. If there is a problem or we are not able to manage, then these are the things. And if part or whole of the nucleus falls in the vitreous cavity, we should not fish around them. It should be removed with the retinal surgeon as your savior. So, pulse are there that you should have a ready anterior vitrectomy at least in your setup. We should avoid hydro procedures in difficult cases. We should lower the parameters if there are suspicion of the PCR. And we should avoid changing the nucleus with the phaco probe, and we should not panic and we should not hesitate to seek help. We have to be Abhimanyu. It is a small video where few things went wrong with me also. It is a very tense and stretched capsule. See, so this is basically not intact CCC, the first step which I was mentioning. Then surgical approach, we have to be very slow. Soft cataract was there, power is very less, vacuum low down. So without disturbing anything, I have not removed the phaco probe, first filling the chamber with the visco and then only removing the phaco probe. This is the vitreous, this is the rent, slow irrigation aspiration, slow removal of the cortex. So, there's a big rent. Here, the mistake I made, I would have implanted 3-piece IOL, but I could manage implanting this. Thank you.
Thank you so much.
Last but
That was-
not the least, I'm going for ARC member, Norjon. Please support me. Thank you very much.
Okay, that was beautiful surgery shown. And Dr. Lal now, he needs no introduction. He will teach us how to manage hard cataracts. He is the director of Delhi Eye Center and is also attached to the Gangaram Hospitals. And he has held and still hold key posts in AIOS and DOS.
So, just on the previous talk, I like to make one comment that whenever there is a PCR, I usually after putting the IUL, contact the people and put the tricot once again and to check whether there is any vitreous into the anterior chamber or not and do the final vitrectomy then. So this is just a video which is self-explanatory. इसका ऑडियो चला देना बेटा ऑडियो चला नहीं
challenges I am going to demonstrate my technique of how to hard cataract, average skill and excellent understanding of the biometrics. Can you hear? While operating hard
I think I'll then go ahead and speak. उसकी आवाज़ बंद कर दो फिर
today I am going to talk about
नहीं नहीं इसकी आवाज़ I'll speak. So I'm going to talk about the hard cataract, how to operate. And you don't have to have the extra talented surgeon, but you need to understand certain basics and certain anatomical facts are to be kept in mind when you are dealing with the hard cataract. We know that the densest part is in the center and the lens is concave backwards. So I'm going to demonstrate my technique of V-trench. I like to make a little wider trench because when you make a shallow trench, you are not able to go into the depth of the nucleus, and because the sleeve cannot get accommodated, sleeve is much wider than the tip, but cutting is done by the tip. And I usually prefer to use the chopper device by the Mohan Rajan. I prefer to use the Kelman tip, and I use a regular tip instead of a micro tip in these cases. So the V trench is like in the diagram you can see. Now when I make a trench which is wider in the periphery, and this is when I rotate, I can accommodate the sleeve, and then it is V vertically down as well. As I keep on going down, the trench becomes narrower, but it reaches to the depth. So peribulbar block has been given in this patient, and if there is any doubt, give a peribulbar block. Capsular access should be little on the larger side, that means around 5.5 millimeter, not more than 6 millimeter, definitely not less than 4.5 millimeter. And after removing the capsule, I do not do any hydro dissection at this stage, because the hard nucleus, when you do hydro and you are trying to make a trench, they keep on rotating and then you got keep on positioning them. So start the trenching without any hydro procedure, then the nucleus is very well stable inside the eye. So go and lift, and now if you see the trench, it is not a central, it is both these trenches are slightly paracentral, which is making a pattern of V, which is much more wider at the periphery than at the center. And as you keep on going, and you can see that it is far more, now there is no rotation of the nucleus. Nucleus is absolutely stable. In harder cataract, you try to, and the nucleus keeps on rotating when you are making a trench. And now I'm not going up to the periphery, I'm just making a small central grooving more. You can see the red reflex coming from the periphery. Now I inject the viscoelastic, remove my chopper, And after nearly more than 80-90% of the trench has been made, now I do the hydrodissection to rotate the nucleus. So that way I am able to make an excellent trench. And once I rotate this nucleus, then you will find that the wider peripheral part comes sub-incisional and will be able to accommodate the sleeve of my phaco tip very well, and I'll be able to really go into the depth of the nucleus without any problem. So once you reach the depth of the nucleus, many times you will find that the nucleus, you have gone to the depth of the nucleus, but there's a posterior leathery plate which does not gives way. And we try to crack it over here, and but the posterior leathery plate is holding on. So the best way is now what I'll do that, I'll hold one end of the one heminucleus with the highest vacuum available on a machine which is 600, and with the chopper I will do the radial split. Instead of having a central split pulling lot of fibers in one go, just at the one end you hold with a vacuum setting. At this time there is no danger of the PC or the capsule, because the whatever may be the vacuum, the tip is absolutely closed, there is no such nothing. And you can see now the fibers split one by one, instead of all the fibers when you try to split from the center, and you can see this slit has gone up to the center. Now I leave this end and rotate the nucleus and repeat the same thing, holding the another heminucleus from the another end and split it up, going up to the center. So this again, and this first split is the most important split in a hard cataract. If you can get this split, then rest of the job is far more easier. But if the leathery fibers are attached, then when you try to take out any hemiligament, it is not coming, you get irritated, you damage the capsular axis with the sharp chopper, and everything becomes very, very difficult. And once this has been achieved, then rest of the surgery is far more easier. And I keep the vacuum settings high, around 600, 650, and use the regular tip so that you have got a good hold, and divide this into as small pieces as possible. Each heminucleus maybe into 4, 5, 3, whatever maximum you can do, and try to make the split goes up to the center. You can keep on removing them one by one, or you can chop them and then remove all of them together. So again you hold it over there and split it, and again see that the split is in the radial direction. Keep on repositioning your chopper. Your chopper has to be very close to the fibers you want to split. It should not be at the periphery. So again and again reposition your chopper, split it, separate sideways, keep on separating sideways, keep on separating sideways, and once you get fibers gone up to the center, then remove this piece. And the first half of the nucleus, my vacuum settings are very high, because as long as some of the nuclear fragment is in the capsular fornices, in the capsular bag, the chances of posterior capsule coming forward are much less. As soon as your bag becomes empty, that is the time when the capsule comes forward. So in the first half of the nucleus, you can actually go at a 600 vacuum settings without any danger to the posterior capsule at all. And this will reduce the danger to the cornea if your vacuum settings are high. Because when the vacuum settings are low, the pieces keep on roaming around here and there, and you are not able to chop it so well, and you damage cornea more. In a higher setting, actually you will be able to suck the pieces closer and will use much less phaco energy. Again, you can see that I'm rotating them instead of pulling them sideways. And once my nearly 3/4 of the nucleus is gone, when I feel now the posterior capsule will have a tendency to come forward, now my vacuum setting will go down. So from 600, I go down to 500, and the chopper also, after chopping the last fragment, I'll prefer to change my chopper to, instead of sharp and a big chopper, I put on a viscoelastic, and then I take now it's not a sharp and a long chopper, I've taken a little shorter chopper now, because I don't want to damage. I put on a viscoelastic to prevent the capsule coming forward. I have lowered the vacuum setting, and now at this stage, the vacuum setting, when the last fragment is there, the vacuum setting is of 400, not even 500. And this may be a little more anterior as compared to the earlier fragments, because I really definitely want to prevent the damage to the posterior capsule. And many a times when I am removing the last fragment, I remove the chopper from the side port to avoid the leakage from the side port. So this way you can see that the nice rhexis and the well-positioned lens, and usually these patients will have clear cornea next day if you follow the basic principles of doing hard cataract. Thank you very much for your kind attention.
That was a very difficult topic made easy, and we could understand how the tenacious nucleus needs to be chopped in stages.
Any questions, I'll be happy to answer.
Can you have a lights on at the back?
I know we have got great surgeons here in India, and everybody has got its own technique of handling the hard cataract, and there are many variations available and many choppers available, so you can use whatever suits in your hand. But the one basic principle what I like most is that do not do hydro, make some amount of trench, because whenever I'm doing hydro in a nucleus, I'm trying to trench, it keeps on rotating and the trenching becomes much more difficult. So once you are done the splitting into two parts and holding at the one end and splitting, you can really, any leathery plate you can split. But when you try to pull it like this, the periphery gets dipped and you may have a damage to the capsule or to the jodule.
Would you prefer to use a sharp chopper or a blunt chopper? And what about the flow rate?
See, as I was talking, the initial stages when the nucleus is inside the eye, there is no danger to the posterior capsule. At that time, my settings are on the higher side. My flow rate is normally 36. And when I come to the nearly 3/4 of the nucleus has been removed, then I lower down the vacuum settings slightly. Flow rate, say when I put on a viscoelastic chopper. I prefer sharp choppers. Reason is when you are trying to worry within the capsule access margin, the sharp chopper goes in far more easily. So particularly first half of the nucleus when you are going, I prefer to use sharp chopper. In the second half of the nucleus when you are going, you can go for a blunt chopper, because now after lollipopping the heminucleus, you can pull the nucleus out of the rhexis margin and then start chopping from the periphery. So don't have to vertically push it down. So the blunt chopper can work because you are pulling from the periphery. Peripheral chop is stronger than a central chop, because once you start chopping from the periphery, it goes up to the center completely. But for the traditional peripheral chop, like our Rajendra Prasad has been promoting temporal chop, which is more or less a peripheral chop, the movements are a little cumbersome because you're about to put your chopper underneath the rhexis margin and go and make it vertically, and on that side the gap between anterior and posterior capsule is small, so looks little risky, little bulky. So to me looks the first half doing the central chop looks much more safer. I can visualize what I am doing. I am not going to the full depth of the capsule. Second half, you can instead of putting your chopper underneath the rhexis margin, you pull the nucleus out of the rhexis margin and start chopping from the periphery. That makes it far more.
That makes it more safe. Thank you, sir.
Not related to this topic, but then since you are here, the experts, one of the pioneers in phaco and writing so many books. So many books. So I just want to ask you one question.
We can hear it. We can hear it.
Practical question. That suppose if you have suspected a very small nuclear fragment gone behind the eyes, or probably you are seeing that a very small piece has gone behind the eyes. Up to wounded very bad. How does that is?
I think, see the hard cataract and particularly in myopics, there is a very high possibility of the fragment getting lost behind the iris, because the myopics iris keeps on going up and down, and the hard cataract, because you are too focused on to being away from the cornea and a capsule, sometimes a small fragment actually you miss it, you are not seen it and it gets missed. So if you are able to find it out that it is there, then you have got no choice, you can't leave it over there, and you will have to make all attempts to take it out. And the first, of course, we try to shake it up slightly, try to suck it here and there, and try to collapse the chamber and see if it can come forward. Otherwise, we'll put on a viscoelastic between the iris and an anterior capsule, and see if we can know that this fragment is say at 3 o'clock, so I have got to go from a 9 o'clock with a rounded depositor and try to pull it out if possible, and mechanically remove it. And even if it takes time, we just can't leave it over there. But one thing I'll point it out to very important, that any time if the patient is having a prolonged inflammation and by any chance the pupil has become accentric on the one side, you have 100% left a small fragment there. So I had one patient and he was one-eyed, very skeptical about everything, and ज्योतिष type की डॉक्टर साहब मेरा ठीक टाइम पे आपने ऑपरेशन नहीं किया, मैं तो ज्योतिष विद्या का. So actually he had inflammation there for 2 months and the not subsiding, and then I saw that the pupil is getting pulled on to the one side. Then I took that patient into the operation theater once again. I could not see the fragment, and then dilated fully, and once we washed, we could see a small fragment over there. So the pupil is becoming in a perfectly all right patient. If the pupil is becoming eccentric, getting pulled up one side, be careful. And any inflammation not subsiding, and if there is any fragment in the anterior chamber, it must be removed. I mean, we should never leave a nuclear fragment. EP nucleus, small EP nucleus can get absorbed, but anything you feel will take more than 2 months to get absorbed, 3 months to get absorbed, probably it may cause irreversible damage to the corneal endothelium, that much of inflammation, so that should be removed.
Sir, one question from my side. Without hydrodissection and nuclear rotation, if you are sculpting, how much zonular dialysis and zonular stress is possible? Will it be safe for the newer people to do that? Because after nuclear rotation, the things become easier and
So
hydrodissection.
in this case, what I showed was we didn't rotate the nucleus at all before hydro, because we only made a trench and then put on a viscoelastic, did the hydro, only then we rotated. But I know one of my good friend, Dr. Tejas Shah, for many years has been talking the cataract surgery without any hydro procedure, but zonules are strong enough to withstand the rotation. So I do, just now we had a talk, suppose you have got a patient whose chamber depth is 2 millimeter, plus minus 0.5 this way or that way. We get many patients who have got a very shallow chamber because of anterior angle closure glaucoma, or because of otherwise hyperopes, or otherwise intumescent cataract, or whatever the region of the chamber depth is less. So after doing rhexis, I do not do any hydro initially. I remove the epinucleus plate up to the rhexis margin and try to suck out little more. Then I make a trench into the nucleus, divide the nucleus, and then try to lift the nucleus as in a posterior polar cataract. If it comes out, it's fine. And if it is not coming out, by the time there is an auto hydro procedure taking place, because the fluid is going inside the eye, and most of the time these nuclei rotate reasonably well without any hydro dissection. So if they rotate easily, you rotate it and consume them. But if you have got any doubt, put on a viscoelastic and go and do the hydro, there is no problem. So you can do the secondary hydro procedure after removing the nucleus. And this technique works very well, very, very well in a very shallow chamber. And this technique can also be tried in a borderline pupil cases. I mean, whenever the pupil is very small, we always use some devices, so there is no problem. When a pupil is very large, there is no problem. It is the pupil size when it is between 4 and 4.5 millimeter. This is where we get confused whether to put on a device or just go ahead and do the phacoemulsification. So in those cases, if you try to do little forceful hydro dissection, and then at that time the pupil may become small. So in those cases also, you can just remove the epinucleus, make a trench, divide the nucleus into two, and see if the nucleus is coming out, it's fine. Otherwise, you can do the hydro after your trenching and all has been done.
This was a really enlightening talk by Dr. Lal, and after this, I don't know how much I can do justice to the topic, but I've been asked to talk on going soft with hard cataracts, almost the same kind of a thing. So, this is Dr. Debashish Datta from Disha Eye Hospitals, Kolkata. So, what is the Brunnesen cataract? It's a dark brown opaque cataract. So, to begin with, somebody who is not very familiar can go ahead with doing an SICS, but it has to be with copious amount of viscoelastics placed below the endothelium. So you can see it's a Brunnesen black cataract being taken out through a superior SICS. But these days, if somebody is efficient, we can go temporal. And temporal SICS gives fantastic results, almost akin to phaco. There may be a little bit of bleeding during the tunnel making because there are two blood vessels, superior and inferior to the lateral rectus, but it takes care of the ATR and gives fantastic results. So if it is too hard, and we start with phaco, and sometimes we are not able to complete it. So ego should be put aside, and we will convert it to SICS. And while doing so, the tunnel should be made liberally. Tunnel should be made liberally. And do not forget to increase the size of the rhexis. The rhexis has to be enlarged, but because the rhexis size required to prolapse this huge nucleus out is huge. So if you do it with a small rhexis, we will end up losing the bag. So in the anterior chamber, it has been brought, and under cover of viscoelastics below the endothelium, you can go ahead with snare, and small fragments can be made, and we can take it out by some toothed forceps, and we can put in a foldable IOL. So now this is a really Brunnesen cataract. You can see it being snared and chopped into 2 or 3 pieces, and with Aruga forceps, intracapsular forceps that there used to be there. If somebody has seen it, so it can be brought out very easily. And we can use astigmatically better cosmesis. Now incision, it is better not to go in for a clear corneal incision. You can give a limbal incision. Limbus is very good. And the tunnel should be pretty long. So it should start in the sclera and should end in the cornea. So this is the ideal type of incision that we should aim for. Capsular rhexis should be a little bit on the larger size, and yes, modulators. One is epinephrine and lidocaine. These hard cataracts require greater manipulation, so there's every chance of the pupil to come down. So it is better to use tropicamide. Nowadays we have this something else with mixtures are available with tropicamide, and BSS Plus is also available. It contains glutathione, which is food for the endothelium. This takes care of the endothelium to a great extent. And viscoelastics, it is better to use viscose chondroitin sulfate, which will stick to the endothelium for a long time, and the soft shell technique is good. Now nuclear retention, to do or not to do? Well, it is your convenience. Usually these days we have small pupil. I am not a very big user of devices. I do use devices, but sometimes I manage by injecting trypan blue below the iris. So if pupil is small, so it is better to use trypan blue below the iris. And here I am using stretch pupiloplasty. That takes care of the pupil to a certain extent, but it may flutter and may come down. So it's a reasonably good amount of dilatation that has been achieved. A direct chop in the pupillary area, because we don't need to go beyond the pupillary area, so whatever we do within the visible area. So because it's a mature cataract, it will rotate easily and do a direct chop. And as Dr. Lal was saying, multiple fragments has to be made. I previously used to joke it on this femto chop. Like you make as many small pieces as you can, but obviously carefully. Hold one. Here you see I've held it once, and this one chop that generates one fragment. I'm still holding on with a very high vacuum. There's occlusion. This is the second chop. And mind you, the separation has to be done slowly in stages, and that separates it, and this is the third chop with one hold. So this is not always possible, but this is at least 2 chops are possible. So you make multiple chops and then go ahead with removing those chops. Now, as there was a question, Dr. Kashyap was saying what will happen to a fragment, because these small fragments, they have every chance of getting trapped below the iris. So you have to take it out at any cost. Otherwise, you may end up with a cornea. And this small pupil, not using devices is not good. That is being I am doing now, because here something is hiding here. So use visco, take your time. A lot of time is taken because take it out. So hide and seek game is there. It has to be taken out at all cost. Now tip and sleeve. So this is the 2.2 mini flare tip, and this is for the 2.8 sleeve. So the tip meant for 2.2 millimeter incision, that the gauge is thinner. So this is for the 2.2, this is for the 2.8. So you can see that the bore of the sleeve is much wider in case of 2.8 normally, and smaller in case of 2.2. So previously we used to have high inflow sleeves in case of legacy machine, those who have used. So it is best, I think, if we can use a 2.8 sleeve with 2.2 tip. That will cause high inflow, sort of. And use in case of hard cataracts, like here I am doing it's a poor man's LRI, which I am doing with a keratome. And this is a 3 millimeter keratome. Sorry. And this has got 4 diopters of cylinder. So LRI has to be done before the main incision, otherwise eye will become soft. So it's a 3 millimeter keratome I am using. So it's a balanced tip for 2.2 millimeter with a 2.8 millimeter sleeve in a 3 millimeter incision. So because it's a hard cataract, there is every chance of a burn. Even with the most sophisticated machines available till date, it is very difficult. It's not easy. It's a tenacious cataract, not that all cataracts can be done with a phacoemulsification. And at any point, one may need to convert. So because it's too risky, so I'm using 2 blunt choppers to make those separations, to make those cleavage paints complete, so that the chops reach up to the posterior capsule. So with viscoelastic, Viscoat in particular, Viscoat means chondroitin sulfate, that is the best protector of endothelium. So because I'm doing a little bit of anterior chamber phaco, because people is, again it has changed. Why does not it work? My gosh. छोटा मैं कर रहा हूँ यहाँ से. Okay, forget about that. Here I have achieved a chop, and there is no epinucleus. As the posterior capsule will be bare, there is no epinucleus as we eat away the fragment. The posterior capsule may flutter and may get may be attracted to the phaco-tip. So I have injected Viscoat on the posterior capsule. So it's an artificial epinucleus which I have created. And why Viscoat? Because it will stay there. Hyaluronic acid like a Hilonjivi will come out as a blob. So Viscoat on the PC in between the nuclear fragments and the posterior capsule. This will prevent my posterior capsule from getting inadvertently sucked into the phaco tip. So here you see there is some amount of phaco there's burn here. So BSS, cold BSS can be dropped in here to prevent the phaco, this burn to the wound. And whenever there is a wound burn, don't think, just put in a suture because we need to sleep at peace. Yes. Now there's a rent, suppose. So this sort of things there's something wrong and it may go down. So what to do? So before going asking for this vitreoretinal surgeon, I would do in some cases inject Hilon GV below the nuclear fragments. This will prevent these fragments from going down for the time being. Then you do a pars plana vitrectomy and do a modified PAL, because a PAL is not advocated because that will cause lots of vitreous traction. So you fashion an incision, but before you fashion incision, make those pars plana ports because it is difficult to do a pars plana port in a soft globe. So you do an adequate amount of vitrectomy, free the masses from the vitreous entanglements, and then deliver it through the SICS wound. Check it with triamcinolone and press a multipiece IOL in the sulcus. And we should always put in a suture because hypotony may be dreadful. Okay. And any suspicion, we should use triamcinolone right at the beginning and not trypan blue because trypan blue may escape through this area. So I've used triamcinolone acetonide at the beginning, and there's so much of vitreous in the anterior chamber. So this blind procedure, irrigation in the anterior chamber, vitrectomy I have marked with a pen. So this amount of blind, I'm going to the pars plana route and doing a vitrectomy. In the anterior vitrectomy, limited anterior vitrectomy with irrigation in the anterior chamber. So this prolapsed and stained vitreous would go back to the anterior vitreous through the zonular gap. That makes things difficult. AC is properly formed, and now we can proceed with the trypan blue staining and the needful. And this is so there is in my hypermature Morganian cataract, what to do? There's no no epinuclear shell. So before your heart throbs, putting your, you can almost hear your heartbeat. So I would advocate that putting a Hilon GV below this lens and put in an IOL before you start your phaco, right into the capsular bag. So it sits there into the capsular bag, and now you can go with phacoemulsification over the IOL. Have a safe New Year. Thank you for your kind attention.
Thank you, Devashish. I think the surgery, what he has shown, requires a lot of guts, a lot of experience, and a lot of palpitation to the heart when people is small, cataract is heart. And the way I had shown you is a much more simpler method where you don't have much of a stress. So
Right.
that becomes, so the thing is you should keep the things very simple. Like in the incision case, it was more corneal. Incision should be limbal always in the heart cataract. Even if you need to cut the conjunctiva, do cut the conjunctiva. That will prevent the incision burn. Secondly, whenever there is you are operating a heart cataract or any difficult situation, because your focus is totally onto the center of the eye. You do not see. You only come to know when you stop that there is a wound burn. So I always tell my assistant to keep on looking at the incision because I cannot look there. So mine cannot see at two places. Then they keep on putting the saline, and I tell them beforehand, you need to pour this saline when I'm not doing anything. That means when my phaco machine is on, don't pour. In between, when I'm not doing anything, you put this saline. Not all the time. And keep on watching. If there's any slightest change over there, inform me so that I can take a step. And most important thing to prevent the wound burn is, whenever we are under stress, we try to lift the handpiece up. It stops the flow from the top floor because the sleeve gets closed over there. You have lifted the handpiece like this. So there is no flow now going from the roof of the cornea and between the tip it gets burned. So you should make an effort to rest your hand onto this sclera. That means you may need to consciously remind you about to keep it pressed downwards. So if your hand is resting on this sclera, then there will be no wound burn because the fluid will keep on going from the top. And these certain of the techniques are very, very special. And if you have got a volumes to learn those techniques in fine, and everybody has to operate within his comfort zone. So if you have got a large volume where you can keep on learning, keep on improving, is fine. But if you think you do not have enough of patients, that means operating say 20, 30 patients in a month, then you should not try anything which is drastically new, whether it's a pre-chopper, whether it's a snare or doing a small people, then you should go to the safest mode of surgery in your hand. It is not no experimentation if you do not have a institutional backup and a large practice. Any others?
Do you have any other speakers left?
All speakers, everybody.
Okay.
Everybody has spoken.
All done. So the photograph? We'll close the session with the photograph of all the speakers and the panelists.